Welcome to Pulse&Pressors, where critical care gets crystal clear. Obstructive shock occurs when a physical barrier prevents normal blood flow, despite preserved cardiac contractility. Because the pump is still functional, rapid recognition and direct removal of the obstruction are essential to prevent collapse. The core mechanism is preserved pump function, coupled with extreme afterload or inflow obstruction. This causes a dramatic reduction in stroke volume, leading to low cardiac output even when the ejection fraction appears normal. The major forms of obstructive shock include pulmonary embolism, cardiac tamponade, tension pneumothorax, dynamic left ventricular outflow obstruction, and mechanical obstruction of the great vessels. Each has distinct physiologic patterns but converges on impaired forward flow. The hemodynamic profile includes low cardiac output, narrow pulse pressure, high systemic vascular resistance, and elevated right atrial pressure. EF may be normal, which makes obstructive shock easy to miss. On echocardiography, obstructive shock often shows a small, underfilled left ventricle and a variable degree of right ventricle dilation. Septal bowing and a non-collapsible inferior vena cava suggest inflow restriction or right ventricular pressure overload. In pulmonary embolism, the RV faces sudden pressure overload. The RV dilates, the septum shifts, and the ventricle becomes ischemic from increased wall tension. This leads to acute RV failure and reduced forward flow. Key echo findings in PE include RV dilation, an RV:LV ratio greater than 1, septal flattening, McConnell's sign, and elevated pulmonary artery pressures. TAPSI often decreases as RV ischemia develops. Hemodynamically, PE produces elevated right atrial pressure, normal wedge pressure, low PAPI, and rising lactate. The RV struggles against massive afterload, producing shock despite a structurally normal LV. Massive PE requires rapid intervention. Systemic thrombolysis remains a primary therapy. Catheter-directed lysis is ideal when available. Vasopressors may be needed to maintain perfusion, and ECMO should be considered for collapse. Tamponade occurs when pericardial pressure exceeds chamber filling pressure. This restricts diastolic filling, severely limiting stroke volume. The ejection fraction may appear preserved, but forward flow is critically reduced. Echo clues for tamponade include right atrial collapse, right ventricular diastolic collapse, a plethoric inferior vena cava, and exaggerated respiratory variation across the valves. The effusion is usually visible and often circumferential. Treatment of tamponade begins and ends with pericardiocentesis. Fluids may temporarily support preload, but definitive drainage is essential. Avoid diuretics, vasodilators, and positive pressure ventilation, which worsen hemodynamics. Tension pneumothorax elevates intrathoracic pressure, reducing venous return and causing RV outflow obstruction. The result is an immediate decrease in preload and rapid cardiovascular collapse. Key clues include absent breath sounds, tracheal deviation, jugular venous distension, hyperresonance, and sudden hemodynamic deterioration. Ultrasound can show absent lung sliding, but treatment should not be delayed. Management requires immediate decompression without waiting for imaging. Needle decompression followed by chest tube placement rapidly restores venous return. Avoid high PEEP to prevent recurrence. Dynamic LVOTO can mimic cardiogenic shock. The LV becomes hyperdynamic and underfilled, generating a severe LVOT gradient. This physiology is worsened by inotropes, vasodilators, and diuresis. Echo findings include a small left ventricular cavity, systolic anterior motion of the mitral valve, a high left ventricular outflow tract gradient, and posteriorly directed mitral regurgitation. EF appears high, which can distract clinicians from the underlying obstruction. Management of LVOTO involves reducing contractility and increasing preload and afterload. Beta blockers are first-line therapy. Vasopressors, such as phenylephrine, may be used to increase afterload. Stop all inotropes immediately. VExUS helps determine whether fluids will worsen congestion or improve hemodynamics. RV failure, tamponade, and PE show distinct congestion patterns. When used correctly, it prevents harmful fluid administration. Obstructive shock demands rapid recognition and immediate action. Echo is the central diagnostic tool. Treating the obstruction directly and supporting hemodynamics with precision dramatically improves outcomes. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.